Hello and welcome to Pathology Scuba, where we dive into disease pathogenesis. My name is Pratima Singh. I'm a pathologist. I wanted to create a set of video tutorials that help walk medical students through pathology topics. And the very first topic I selected for discussion is myeloma. When I teach pathology, what I try to do is take the pathogenesis of a disease process and explain how features of that pathogenesis yield the specific clinical manifestations you might see when a patient has that disease process. I believe that that allows for a more intuitive grasp of these disease processes. As mentioned, this material is created with medical students in mind, particularly medical students who are learning about pathology. This material is benefited from having some pre-existing information, such as cell histology and immunology. People who don't have that type of pre-existing education may not grasp many of the concepts we're talking about. On the other hand, this is also not ideally suited for practicing physicians. There are levels of nuance and complexity about these disease processes that are beyond the scope of this short video. So to independently diagnose and treat myeloma in a clinical setting, you would require a lot more information than I will be discussing today. Before we start talking about the pathogenesis of myeloma, let's take a moment and talk about the etymology of myeloma. Myel is from the Greek word for bone marrow. Oma indicates a neoplastic entity, so the combination of myel and oma gives you myeloma, a neoplasm of the bone marrow. Myeloma and multiple myeloma can be used interchangeably, although multiple myeloma has been used far more commonly. And the word multiple comes from the fact that many sites in an affected patient's body may be affected. There is another word that can be used, which is plasma cell myeloma, to indicate the same disease process. That's an apt description because in the bone marrow, we have multiple cell lineages. However, multiple myeloma represents a neoplasm not just of any bone marrow cell, but specifically plasma cells. In this particular image, you can see bone with bone marrow showing the site of derivation of these myeloma cells, these abnormal plasma cells. So how does multiple myeloma develop? There is a preceding state called a monoclonal gammopathy of undetermined significance, sometimes shortened to MGUS, from which multiple myeloma evolves. Understanding the concept of monoclonal gammopathy is important. We use that term a lot. Sometimes we don't break it down so that you understand what we're talking about. The word gammopathy literally translates into a disease condition of gamma. So does gammopathy really mean a disease condition where we have too much gamma? Yes, quite literally that is what it means, but not this condition of too much gamma. So let's look at what gammopathy really means. And in order to understand that, we need to look at a special test. We need to look at a protein electrophoresis. A protein electrophoresis will enable us to separate proteins in a given sample according to their innate electric charge. So as you move from anode to cathode, various proteins will precipitate based on their charge. You may notice that the most dense band on this sample of human serum corresponds to albumin, which, as we know, is the most prevalent protein in human serum. Other proteins will precipitate out in the alpha 1, alpha 2, beta 1, beta 2, and gamma regions. You may notice some substances underneath that you recognize, like alpha 1 antitrypsin. Some of these names derive from the electrophoretic pattern. Now we're concerned about gammopathy, so let's see what's in the gamma region. As you look down here, you'll notice multiple immunoglobulin classes. And this is what we care about. If you recall, when I showed you that image of multiple myeloma cells coming out of the bone marrow, there weren't just plasma cells in that image. There were also the immunoglobulins that are being produced by those plasma cells. And this is an important concept to understand. When you run a serum electrophoresis, it's helpful to have a densitometer tracing the density of these bands. As you can see, it's more visually appreciable and allows for quantification of the various bands. So albumin in a normal situation should be the solitary high peak with minor peaks along the alpha, beta, and gamma regions. Take a look at this abnormal situation. You have the high peak for albumin still, but then there's a second peak over here in the gamma region. So this is indicative of a gammopathy. This is a sample from a patient with a monoclonal gammopathy. So we've explained what we mean by gammopathy. How do we prove monoclonality? The second test we can do is called an immunofixation. So we take our area of concern, this gamma peak, and we explore what constitutes that gamma peak. We run it across an immunofixation gel. If you notice on this particular gel, we've got some extra labeling. We've got IgG, IgA, IgM, and the K and the L stand for kappa and lambda light chains. These lanes have been pre-treated with antibodies against those particular immunoglobulin classes or light chains. So whatever precipitates out along those lanes is what is present. And in this case, we see IgG and we see lambda light chains. Let's go into our architecture of immunoglobulins briefly so that we can have more conversation regarding these particular findings. This image shows the structure of an antibody, and you'll probably recall that there are multiple classes, and this is determined by the heavy chain represented in blue. So this heavy chain might indicate that this is an IgG, IgA, M, D, or E antibody class. When we're talking about myeloma, incidentally, most of the monoclonal antibodies created in myeloma will be IgG. In about 20 cases of myeloma, the monoclonal immunoglobulin produced is IgA, and it's vanishingly rare to get myelomas that are associated with IgM, D, or E monoclonal antibodies. Moving along, light chains are those smaller units that are either kappa or lambda in nature. When you look at a normal constitution of plasma cells, recall that they would be considered polyclonal, and they would independently produce whatever antibody was appropriate, which would mean that we would have an admixture of multiple antibody classes and an admixture of kappa and lambda light chains. So a normal immunoglobulin fixation would show you IgG, IgA, IgM, and kappa and lambda all represented together. However, that is not what you saw on the immunofixation gel I showed you earlier, so let's contrast that against the pattern here on the right. It looks quite a bit different. Now everything has vanished except for very dense IgG and lambda. So what this indicates is a monoclonal plasma cell population creating all the same antibodies. Again, one clone, one antibody. So this is evidence of a monoclonal gammopathy. So we have a monoclonal gammopathy indicating that there is likely a plasma cell clone. Do we now have a diagnosis of multiple myeloma? No, not necessarily. There are other things that can do this. The preceding disease state, monoclonal gammopathy of undetermined significance, may be responsible for this finding. Other disease processes can also give you a monoclonal gammopathy. There is an entity called Waldenstrom's macroglobulinemia, which is associated with lymphoplasmacytic lymphoma. However, the monoclonal protein in this is an IgM paraprotein. So in this case, where we have IgG, we wouldn't be particularly considering Waldenstrom's macroglobulinemia, so we'll eliminate that. But still, we're not quite sure this is myeloma yet. So how do you get from monoclonal gammopathy to the diagnosis of multiple myeloma? One of the first diagnostic tests you can run is, of course, a bone marrow biopsy and aspirate. Why don't we look at the bone marrow cellularity to see if there is an increased and or abnormal population of plasma cells there? For a histology recap, these are the plasma cells. You see a round dark nucleus, you see abundant cytoplasm, and you see a perinuclear clearing, often called a perinuclear HOF, that identifies these as plasma cells. Sometimes these plasma cells look quite normal, although increased in number. Sometimes the plasma cells associated with myeloma are enlarged. Sometimes they have immature features like nucleoli. But there's even more you can do to identify these particular plasma cells as being part of a myeloma clone. You can stain these plasma cells. CD138 is an excellent marker of plasma cells, and these dark brown dots show us where all the plasma cells are in this histology section. Then apply kappa and lambda light chain markers. A normal population of plasma cells would be expected to show both kappa and lambda, but that is not what's happening here. The vast majority of these plasma cells, as seen on this 138 stain, are staining in a restricted manner for kappa. So we have proven that there is clonality. The other thing you want to do is quantitate the percentage of plasma cells in the bone marrow. If you have 60% or more plasma cells in the bone marrow cellularity, that's diagnostic in multiple myeloma. Now, what if you don't quite have 60? Well, if you've got 10% or greater, but you don't quite make it to 60, you need more to make a diagnosis of multiple myeloma. What more could you possibly need? A side of crab. Monoclonal gammopathy plus marrow plasmacytosis. Enough plasmacytosis makes the diagnosis. Not enough, so less than 60%, you add some crab. And what am I talking about when I say crab? I'm talking about the evidence that this myeloma clone is damaging areas of the body. It stands for elevated calcium, impaired renal function, anemia, and bone lesions. Again, this is the end-stage detrimental effect that either the neoplastic plasma cells or the antibodies that they are producing are going to have on the body. Let's go through those crab criteria one by one. First letter, C. That's elevation of calcium. Think about it. Where do we store most of the calcium in our body? Fully over 80%. It's in our bones. So when we have osteolysis, we get hypercalcemia. If you think about a plasma cell neoplasm destroying, lysing bone, that released calcium goes into the bloodstream, resulting in hypercalcemia. This mechanism is called local osteolytic hypercalcemia. Hypercalcemia is important to be aware of because it is potentially the way a patient with multiple myeloma will present with specific symptomatology. They can have dramatic changes, including altered mental status, cardiac rhythmic disturbances like short QT, not like this short QT, like this type of short QT on an electrocardiogram. They can even have seizures as a result of this hypercalcemia. And of course, these are very dramatic. But hypercalcemia can also be a little bit more subtle. It can provide a patient with vague symptoms like nausea and constipation. So you have to be aware of these potential symptoms and identify hypercalcemia and the potential that that may be due to, among other things, myeloma. How about the R in crab? Renal insufficiency. Again, renal insufficiency is very important to be aware of. This is highly prevalent in patients with myeloma because there are multiple ways in which myeloma can affect the kidney. The predominant way myeloma affects the kidney is due to the immunoglobulins that have to be filtered through the kidney. These immunoglobulins combine with the TAM horsefall renal glycoproteins to form these sticky, dense casts. They get stuck in the tubules. You see these casts stuck in the tubules here. For contrast, these are more open, empty tubules. But these are stuffed with these casts, and that is essentially going to cause a situation where those tubules are clogged. The tubular epithelium will also become damaged as a result of these casts. As those tubules fill up with those casts, we can start to spill light chains into the urine. That can result in proteinuria. Incidentally, proteinuria can also be the initial identified sign that someone has myeloma. Keep in mind, when you have proteinuria, you can do the same testing that you do on serum. Over here on the right, you have a serum protein electrophoresis, or SPEP, and just as we've talked about, this one shows a gammopathy. Over here, we have a urine protein electrophoresis, also known as a UPEP, and it shows a similar spike because those free chains are in the urine as well. In the serum, you're more likely to see an intact restricted antibody, IgG kappa in this case, whereas in the urine, you may uniquely just spill the light chains. Incidentally, there is a name for light chains in urine in these patients who have myeloma. These are our Bence-Jones proteins. Another way renal insufficiency can occur is through amyloidosis. Amyloidosis in myeloma is systemic in nature, which means that it can affect multiple organs, not just the kidney, the heart, the liver. You can find it in soft tissues as well. But when it occurs in the kidney, it is a source of renal insufficiency. Take a look at this glomerulus that has this bubblegum pink material. That's amyloid. So you can already appreciate that this would interfere with glomerular function. If you want to prove that that is amyloid, you do a Congo red stain. Congo red stain in the presence of amyloid will show a characteristic color of birefringence when you look at it under polarized light. And that color of that birefringent pattern is known as apple green birefringence specifically. So if you see apple green birefringence, that's indicative of amyloidosis. Now, for those of you who are remembering your amyloid really well, you might remember that there are multiple types of amyloid. So what type of amyloid would you see in this condition, in this myeloma condition? It's AL amyloid. Why AL? Well, the L stands for something. Can you guess what it is? Light chain. So AL is light chain amyloid. That's why this is the amyloid that occurs in association with myeloma. The A in crab is anemia. Anemia can occur through multiple mechanisms. The myeloma can infiltrate the marrow to the extent that inadequate erythropoiesis is occurring. Interleukin 6 and other suppressive cytokines can reduce red cell production. And then the presence of renal disease, if severe enough, can result in decreased erythropoietin being elaborated from the kidney, which then adds to the anemia. With all of this going on, it shouldn't surprise anybody that of all the CRAB manifestations, the most commonly seen one in myeloma is in fact anemia. It's the most universally seen sign associated with myeloma. Finally, we have the B, bone lesions. When myeloma involves bones, it's described as having a punched out appearance. It's very lytic. This is a very destructive process. In this radiograph, you can see a lytic lesion of the humerus in a patient with myeloma. Take a look at the punched out appearance of these multiple lesions in the cranium here on the right. This is classic of multiple myeloma. And again, this is where the word multiple came from because of these multiple lesions. When you look for myeloma lytic lesions in radiology, you can do multiple different types of tests. You can get plain radiographic films, you can get a CT scan, MRI, PET scan, but there's one test that you wouldn't want to order, a nucleotide scan. In cancer patients, bone nucleotide scans are commonly employed to look for particularly metastatic disease. In this patient, you see multiple dark spots, especially in the long bones, indicating sites of metastatic disease. The reason why bone nucleotide scans work so well is because when cancer involves bones, it typically elicits a reaction. But this doesn't work in myeloma because in myeloma, you get a purely lytic lesion. Myeloma essentially dissolves bone. There's no reaction, so a nucleotide scan would not be positive. Now, I'm telling you this, and I know this seems like a fine detail, but I'm telling you this for three reasons. First of all, this ties into the physiology of what's going on with this condition, this myeloma condition. It is so lytic, and these bones get so soft, and pathologic fractures definitely can occur. The second reason I'm telling you this is because this is a clinical pearl. This could be something that you could wow them on your wards if you know this particular piece of information. And the third reason I'm telling you this is because you're going to have a patient with myeloma someday, and you're going to have to know that you don't want to waste time and money doing a nucleotide scan because it is not going to work. So multiple myeloma, we've talked about monoclonal gammopathy, we've talked about the pathology of the plasma cells, and we've talked about the clinical CRAB criteria. But I want to speak with you about one more aspect of myeloma, which is hyperviscosity. Hyperviscosity in myeloma can lead to complications relating to thromboembolic phenomena like stroke, like deep venous thrombosis. But there's also another pathologic finding associated with myeloma that you can see on the peripheral smear. It's called reuleaux formation, where hyperviscosity results in red blood cells adhering to one another. Here's another image showing that reuleaux formation. If you think that these adherent red cells remind you of a stack of coin, you probably agree with the person who originally described these as rouleau because rouleau literally means stack of coins. Here's something interesting about rouleau formation. We talk about it in association with multiple myeloma, and this is because of the hyperviscosity caused by the presence of those excess immunoglobulins. But what is the antibody that's present in most multiple myeloma cases? It looks like this. It's an IgG. This particular IgG antibody doesn't tend to cause significant enough hyperviscosity to create rouleau formation unless it's present in excessive quantities. Now, if you had a more complex antibody, maybe one that looked like this, or one that looked like this, you can imagine that it'd be much more likely to get a viscous serum creating this rouleau formation. All that is to say that rouleau formation is much more common if you have a dimeric antibody being produced, like in our cases of IgA myeloma. But it's even more common when you get a pentameric antibody class, which is, of course, IgM. And we don't tend to see IgM in myeloma. We tend to see it in a different disease that I mentioned earlier in the talk, our lymphoplasmacytic lymphoma with Waldenstrom's macroglobulinemia. All this is to say, even though rouleau formation is classically associated with multiple myeloma, it actually isn't seen in myeloma as often as it is seen in Waldenstrom's macroglobulinemia. Now that we've discussed multiple myeloma from the standpoint of monoclonal gammopathy, plasma cells in the bone marrow, the Crab criteria, and hyperviscosity, you should be well prepared to answer questions relating to myeloma. Take a look at this vignette. You can even pause this presentation briefly, but can you identify the characteristics of myeloma in this vignette? Can you identify the Crab criteria? Would you be able to answer the following questions? This brings us to the end of our very first pathology scuba dive. I wanted to leave you with this image of a crab. Many of you may already know this, especially those of you who are the astrologic sign Cancer. But the word Cancer derives from the word for crab. And the reason why this word was used preferentially is because solid malignant tumors have these irregular extensions, kind of looking like the claws of a crab. To find out a little bit more about this, you could read the book The Emperor of All Maladies, a biography of cancer by Siddhartha Mukherjee. It's a wonderful read. I highly recommend. It's fascinating. I've been Dr. Pratima Singh. It's been a pleasure sharing my passion for pathology with you. I'll be releasing more video tutorials. If you want to subscribe to this YouTube channel, you'll get them as they are released. Thank you.